Righty ho. Hi guys, my name's Pagan. I'm one of the non-training paediatric surgery registrars that works here at the Women's and Kids Hospital in Adelaide. And Siva has asked me to do a quick presentation for you guys on essentially common paediatric surgical conditions. And I think when you're a student, a lot of the things that go through essentially around exams and OSCEs. And so this presentation is very much geared towards giving you guys the knowledge that you're going to need to pass these exams. And then later when you're a doctor and you actually want to do the specialty, we can tell you more about it if that makes sense. How do I stop this beeping? All right, but we shall survive with the beeping. I'm sure that'll be fine. What you want me to?
I think we'll go right.
Easy. Okay, so what we'll do, guys, with this presentation is we'll try make it as interactive as we can to try get kind of the most knowledge out of the conditions that we'll talk about. So essentially what we'll do today is we'll talk about an approach to abdominal pain and talk about a few conditions using kind of case studies as we go along to learn. Then we'll move the approach to vomiting, then talk a little bit about groin swellings and finish it off with a bit of pediatric urology. And I suppose that next sentence is discuss common pediatric surgical complaints, their presentations, investigation and management will kind of just happen as we go along. And again, this is mostly to help you guys pass your writtens and your OSCEs, which unfortunately your life is centered around at the moment. Before we get into it, if you guys have any questions along the way, I've got this little chat window set up here. So you can like type your questions if you don't feel confident asking, but please, if anybody has any questions going through and they just want to like speak them, just speak them. I'm sure I'll be able to hear you guys. Righty-ho. So the first case is of a 10-year-old girl who presents to the emergency department with 2 days of right lower quadrant pain and decreased appetite. I suppose the first question to ask to you guys is what further questions would you guys like to ask when taking a history from this young girl? Now, how many people do we have in this thing? Okay. Oh, yo, there's so many of you. Okay, this is going to be great. Does anybody want to try maybe just a few further questions that you'd like to ask on history for this girl? Keeping in mind if somebody doesn't pipe up, I'll probably just randomly call out names from this list.
Is there any other GI symptoms? So vomiting, diarrhea?
Perfect. Yeah. So, yep, there has been a bit of vomiting. No diarrhea though.
I'd want to do a plot radio of the pain. So if this happened before, if there was a change in the location of the pain, if she's able to sort of describe that.
Yep.
What type of pain it is, that sort of thing.
Yeah, sure. So you're looking for like the site, onset, duration, like character of the pain and stuff like that. Is that what you're saying?
Yeah.
Yeah. No, that's perfect. And what kind of what I think you were describing it, but what kind of thing are you looking for when you're talking about radiation of pain or like movement of pain? What's the key kind of thing that you're trying to tease out in that history?
If the pain sort of started off more central or generalized and now it's more localized to the right lower quadrant.
Yeah, exactly. And I'm sure you know this, but we call that migratory right lower quadrant pain. And we can talk about a bit more about that when we talk about appendicitis itself. So yeah, a deep dive into the pain. It sounds like, is your guys' version plot radio like a mnemonic for something, is it? Or is it something else?
Yeah, the plot radio is like Socrates, like that sort of.
Beautiful. Yeah, Socrates is what we use in New Zealand. But yeah, plot radio sounds great. As long as you've got some system to kind of go through like deep dive into pain. That nausea, vomiting, GI symptom stuff is great. Anything else that anyone would like to ask?
You would probably also want to know if she's had any recent infections in case you're thinking of something like mesenteric adenitis.
Good. And what kind of infections mostly are the preceding infections to mesenteric adenitis?
mostly viral ones.
Yeah, exactly. Yeah, that's a very very important part of the history. Any other questions?
You could ask if it was like painful on the drive over, like going under the dumps.
Yeah, some specific stuff, because I suppose what that's trying to do is elicit whether or not the child has peritonitis, right? So on very slight agitation of the abdomen, is there reproducible pain in the exact same place? Because I think probably what you're describing is that kind of phenomenon when people say, every time I hit a bump in the road, it hurt in exactly the same spot. Is that what you're trying to say?
Yeah.
Yeah, perfect. Yeah, that's really, really good point. That's true. Anything else?
The hamburger test, or like if I were to offer you your favorite meal in the world right now, would you eat it?
Yeah, that's a really, really useful question. And for me, when I'm seeing somebody in ED, like appetite is a really big thing, because in appendicitis, and I think obviously we're all thinking about right lower quadrant pain and appendicitis, 80% of children will have a reduced appetite. And it does leave 20% or 1 in 5 that won't, but it is really, really important. And it helps for me at least to stratify who I'm actually worried about, if you know what I mean. Cool. So we've done kind of a bit of a deep dive into pain and other GI symptoms. Any kind of, and like viral prodromes and things like that. Any other questions that you want to ask about perhaps other systems that might be affected?
Any urinary changes?
Yeah, perfect. And what kind of specific urinary changes are you asking about?
Blood in the urine increase, or like decrease or hesitancy with urination, I guess as well.
Mm-hmm. Yeah, because I suppose with the line of question about urinary symptoms, essentially what you're trying to do is exclude a urinary tract infection, right? And so for the older kids, it's about asking about, is there any dysuria, frequency, malodorous urine, flank pain, loin pain type stuff, those like classic urinary tract infection symptoms. Unfortunately, with children, those symptoms sometimes aren't as well developed as they are with adults. And sometimes children will describe what's called abdominal dysuria. So they'll say, it hurts in my tummy when I go to pee. Now, usually that doesn't mean that they've got a urinary tract infection. What it means is that when they generate sufficient intra-abdominal pressures to urinate, they also irritate, the nasty appendix that they have, or the mesenteric adenitis that they have. So heaps of stuff about pain, GI symptoms, urinary symptoms. Any other kind of symptoms, maybe not in a 10-year-old girl, but maybe in a 14-year-old girl that you're going to want to ask about?
Menstrual history.
Yeah. And I think with a gynae history, the things that I focus on are, 1, have you started having periods yet? 2, are you usually regular or usually irregular? 3, are your periods usually really sore? Which is obviously subjective. Are your periods usually heavy? And then what I ask is, could you be pregnant? And I suppose what you're driving at, and you'll kind of get a theme of this when, like, as we kind of go through this presentation, but I usually don't ask questions unless the answer to the questions is going to change what I do. So the reason why I'm asking all the urinary symptoms is to make sure to exclude a UTI before I commit a kid to an operation. The reason why I'm asking all these gynae questions is to exclude a gynecological cause of the pain before I commit them to an operation and antibiotics. The reason why I'm asking about viral prodromes is to make sure they don't have mesenteric adenitis before I commit this kid. Those are the kind of ones that we'd ask usually. Sexually transmitted infections are usually pretty uncommon, luckily, in like the pediatric population, but it's still really important to ask, especially in the older kids, 15, 16. Obviously, like, are you sexually active? How many sexual partners do you have? If so, like, do you use protection? Do you use contraception? All these things. There's only one other thing that's probably important in terms of history for this child. Anyone know any other symptoms that we'd ask for this kid or any kid? It's okay if you don't. So the the other main one that I would always ask about, and I think it's probably because it's so obvious that people haven't thought about it, is fever. Yeah. So the absence of fever is pretty good in terms of excluding appendicitis. Obviously, there'll be a proportion of kids that have early appendicitis and haven't developed a fever yet, or a proportion of kids that have, acute appendicitis or even complicated appendicitis without fever. But the presence of fever adds evidence or credence to your differential diagnosis if you're thinking about appendicitis. Before we move on to the next question, which is about abdominal examination, did anybody have any questions about history taking in a child with abdominal pain? And the only reason I ask is because you very well could get given an OSCE with this exact kind of stem, like this 10-year-old girl presents with 2 days of right lower quadrant pain, please take a history. And I suppose what I want to do with this presentation is equip you with the knowledge that you need about what questions to ask so you can successfully fly through that OSCE. No? Okay, let's move on then. Righty-ho, does anybody have a system, like a systematic way of examining the abdomen that they'd like to share? Because the other OSCE that you could get is this exact same scenario, this 10-year-old girl, 2 days of right lower quadrant pain, please perform a abdominal exam. Anyone have a good one that they want to share? Oh, I'm dangerously close to calling people out. No, that's fair enough. Like, I to be honest, like, I think at 4:30 in the afternoon on Tuesday, it's not unreasonable to just kind of want to be told. So that's fair enough. So shall we talk about what my approach to the abdominal exam is if I was a 5th year or 6th year looking down the barrel of an OSCE, okay? So what I would do is if there's a patient there and they've asked me to do it, I'd say, look, the first thing that I would do is I would do a general inspection of the patient and decide in my head whether or not they look well or unwell. The second thing that I'd do is look for clues around the bedside as to the state of their wellness. Like, do they have fluids already running? Are there like antibiotics already up? Do they have a line in? Do they have a parent that looks very concerned next to them? And then I would dive into my systematic approach. And the catch-all phrase that I do when I start is I say, for a complete gastrointestinal exam, I would first start with the hands, but because I've been asked to do a focused abdominal exam, I would start with the abdomen. The first thing that I'd do is I'd do a general inspection of the abdomen itself. And the things that I want to know is, does the abdomen look distended? Are there any skin changes on the abdomen? Are there any focal masses of the abdomen? And then a general thing is the child look like they really don't want me to touch their abdomen? Okay. At this stage, in an adult, you'd move on to palpation of the abdomen. In a child, usually what I like to do is take a less invasive approach. And this will work for some and it won't work for others. Usually what I ask children to do is to take a big breath in and make their tummy real skinny. And then I ask them to take a big breath out and make their tummy really fat. And then the third thing I ask them to do is to do a big cough. Now, all of those maneuvers, sucking your tummy in, making your tummy really fat and doing a big cough, are trying to elicit whether or not the child has peritonitis before I even touch the abdomen. Right? So if those maneuvers are causing reproducible pain exactly where the child said it was before, the likelihood is that they're going to have some kind of pathology. Right? And what it also allows me to do is localize the pain before I even touch the kid. Okay. The next thing I'd move on to is palpation of the abdomen. Now, I suppose the big thing in children, especially younger children, is that there's not really a role for like deep palpation. Yeah? So most of the time it's just light palpation. Same thing as last time as adults, is that you start as far away from where the child says it's sore as possible. The phrase that I would use in an OSCE is I would do light palpation on the abdomen, centering around either the 4 quadrants, left upper quadrant, right upper quadrant, right lower quadrant, and left lower quadrant, or the 9 regions of the abdomen. Either way you do it, all you have to do is be systematic to make sure you don't miss a portion of the abdomen with your palpation. The next thing that I would do is I would percuss the abdomen. So again, I'd do percussion in the 4 quadrants or the 9 regions to elicit whether or not the child has any percussion tenderness. Then in children, I think there's a limited role for auscultation when it comes to an abdominal exam for a child. So to the point where I do not do it. In your exam, I would say I would auscultate the child, but it doesn't result in any clinical benefit for the child. So I don't do it. Now, in children, especially, so you hear this phrase in adults, but in children and especially, what I would say at the end of my palpation is I would say, I would also examine the external genitalia and check for hernias in a child to ensure that there's no other pathology accounting for their abdominal pain. And that's it. There's a bunch of special tests that we might talk about when we talk about appendicitis specifically, but that's my general approach to the abdominal examination in a child. Does anybody have any questions about that or anything they want to add or anything that they're uncertain about? No? Okay. So now this one I won't do. I'm going to make you guys do this one. What would be your guys' differential diagnosis for this 10-year-old girl if this is the only history you have? So 2 days of right lower quadrant pain and decreased appetite.
Appendicitis, mesenteric adenitis, gastroenteritis.
Yep.
Maybe a Meckel's diverticulum.
Yep.
Yeah.
That's good. We're up to 4. Let's get to 10 before we stop. You don't have to do all the heavy lifting yourself, Port Lincoln, but you've got 4 out of 10, so you're almost halfway. 10 is just an arbitrary number. It's more to demonstrate that there's going to be a lot of different things that this could be. So, yeah. Yep. So the other suggestions from here were a inguinal hernia, a small bowel volvulus. Yep, very possible with malrotation. So we're at 6. Anybody else want to suggest any others?
UTI.
Urinary tract infection, we're at 7.
Renal stone.
Yep, renal stone, we're at 8. Yep, ovarian pathology. And what ovarian pathology specifically?
Ovarian cyst rupture.
Yep, so ovarian cyst accident. Cool, we're at 9.
Gastroenteritis.
Already been sent. But yeah, no, that's fine. That's fine because that's going to be the vast majority of the diagnoses for girls that present with this. Like, although like appendicitis is extremely common with a 10% kind of lifetime risk, it's still going to be the uncommon thing or the exception rather than the rule with children that present with this. So any one more?
Inflammatory bowel disease.
Yeah, perfect. We've reached 10. So yeah, inflammatory bowel disease definitely could be. It's not outside of the realms of possibility. The things that I like to do, so well done guys, because that's not an easy thing to do. The only reason that I'm good at this is because I do it every single day of my life. And you would be way better than me if you did it as often as I did. So the way that I like to generate a differential diagnosis when I kind of up against the ropes and a consultant's asking me, or if I'm in an exam, is usually I like to group it by systems, which is kind of what happened. So we said, okay, there's GI system problems. So that was gastroenteritis, appendicitis, mesenteric adenitis, Meckel's diverticulum, malrotation with the volvulus, inflammatory bowel disease, intestinal obstruction could present like this, interception, like a whole bunch of different things. And then I say, okay, cool, those are the gastrointestinal ones. And then we look at the urological ones. So urinary tract infection, ureteric stones, pyelonephritis, and then you kind of go into gynae things like ovarian cyst rupture, Mittelschmerz, pelvic inflammatory disease, just really bad dysmenorrhea, and then you can go into MSK type stuff as well. So you can be like, hematoma from like an injury or like just pulled muscle, pulled tendon, like there's so many other things. And even just doing that, we got to like 14 or 15. So that's just a tip that I would kind of have for when you're generating a differential. That's the easy way to do it. So you can
Or
even
just considering, oh,
Yeah.
sorry,
No,
her
you go. I'm just yarning. You go.
just like considering her age in terms of pelvic inflammatory disease.
Yeah.
Are there
Good.
many other causes other than sort of your sexually transmitted?
No. So, well, sorry. Yes and no. So in adults, the proportion of pelvic inflammatory disease, and all the studies come from adults, right? Because there's not that many kids that have pelvic inflammatory disease. But the 90%, or 9 out of 10 women that have pelvic inflammatory disease will be of a sexually acquired etiology. But that still leaves 10% or 1 in 10 that get it without having like a primary sexually transmitted infection as their inoculation. And usually those individuals have a gastrointestinal pathology that results in perforation that's been missed, and that perforation results in enteric spilling down to the dependent part of the abdomen, which is the pelvis, and then you get the pus and the pelvic inflammatory disease from there.
Okay, so it's less so that it's actually ascending,
Yes.
obviously, in kids sort of thing. Yeah.
Yeah. And in children, if you see pelvic inflammatory disease, unfortunately, a lot of the time it's sexual abuse, and they're always really sad cases.
Yeah. Okay. Thank you.
That's all good. So what investigations would people like to request for this 10-year-old girl? Nothing is wrong. There's just different shades of right.
Abdominal ultrasound.
Nice. So we got to the clincher really early. And this is the ultrasound department in the Women's and Children's Hospital Adelaide is an outlier. So everywhere else in Australasia, ultrasound is actually relatively shit. So it's not as good at diagnosing acute appendicitis, which is a thing that you're trying to diagnose, as it is here. So here at this centre, the detection rate or the identification rate of any appendix in a child sits around about 95 to 97%. So they can identify the appendix the majority of the time. Other centres probably sit more around about 50 or 60%. And some centres even lower than that. And so although ultrasound forms the mainstay of investigation at this centre, it's more just that, at other centres, you might come across less useful ultrasounds than here. At other centres, what ultrasound is used for, because at other centres, they say appendicitis is a clinical diagnosis, can be made off history, exam, and bloods alone. And so what they use an ultrasound for there is for their girls, to exclude tubo-ovarian pathology before you commit a child to an operation. But yeah, abdominal ultrasound is good. You don't need to know any of this, but just so it's recorded here for posterity, the ultrasound findings are a blind-ending, non-compressible tube that measures greater than 7 millimeters with associated hyperemia, wall thickening, and echogenic mesentery. Those are the positive findings in an ultrasound that has appendicitis. Cool. Any other investigations other than ultrasound?
Inflammatory markers?
Yeah. So you're talking about blood tests, hey?
Yeah.
Nice. And what specific inflammatory markers are you yarning about?
CRP?
Yeah. That's I love CRPs, right? Because we're like surgical registrars. So CRPs are great. Do you know a scenario in which a CRP might not be useful? Or let me phrase that differently. Do you know a scenario in which a CRP might be falsely reassuring if it's low?
If it's early, I think.
Yeah. So my general rule is that a CRP within the first 24 hours of the development of abdominal pain, I don't really pay attention to too much if it's normal. Like if it's like really high, so say it's like 100, I'm just like, okay, yeah, that's real. But if I have a child that's had like 9 hours of abdominal pain, they've got a normal CRP and even a normal white cell count, I'm just like, they may have normal inflammatory markers because they're too early on in the piece to have the compensatory reaction from their appendicitis, if that makes sense. So bloods, and we talked about a white cell count and a CRP. Any other investigations that anyone wants to do? Yeah. So that would definitely be something that would do for almost every child. So we'd do, for everybody that missed that, we'd do a midstream urine with a dipstick to start out with, to kind of exclude a urinary tract infection before we commit a child to an operation. And you'll hear me say that sentence a lot, before I commit a child to an operation. And I think it's because it only takes like one time for you to commit a child for an operation, something go wrong, and then not be appendicitis for you to really kind of think about what you do. So the things that we'd look for on a dipstick, two things that I care about: the presence of white cells in the dipstick and the presence of nitrites in the dipstick. The problem is with inflammatory pathology inside of your tummy, because it can cause irritation of the bladder. So say if you've got a pelvic appendix, which is right next to the bladder, it's all big and nasty inflamed. The bladder's kind of producing white cells just to respond to that. You may get a urine analysis that has, positive for white cells. The key is if it's negative for nitrites, that's okay. I'm not going to call that a urinary tract infection. But if you've got both nitrites and white blood cells, then I'd want to culture that urine to make sure they don't have a urinary tract infection. And I probably, without an ultrasound that's positive for appendicitis, I would not check that child for an operation. Okay, before we move on from this case, because we're going to talk really quickly about the individual conditions. Anybody have any questions about that? No? Okay, let's, this is more just so it's written down for you guys, so you can kind of refer back to it and be like, okay, these are the important points for appendicitis in a written thing or in an OSCE. So appendicitis, I've tried to dumb it down, so like it's just like literally the bare bones of things that you just need to know, so it's high yield. So appendicitis, inflammation of the appendix. It sounds dumb, but sometimes somebody will ask you, what's appendicitis? And you'll kind of go on this big tangent when really all you need to say is that. It's the most common it's the most common pediatric emergent abdominal operation, a laparoscopic appendicectomy. Has a 10% lifetime risk, so 1 in 10 out of all of us will have appendicitis at some point in our lives. The most common age group in the pediatric population is between 10 and, I suppose for us, 16 years old, but 19 years old. It's quite uncommon in the under 5s. Like it does happen, probably about 9 to 15% of all appendicitis in ped surge will be in the under 5 age group. But often when like Edie called me with this 2-year-old that I think has appendicitis, like I immediately kind of switch off. I'm like, this is unlikely. It's not impossible, but it's unlikely. It's a little bit more common in boys. The key history points that we're talking about was migratory pain. The pain's usually constant, so it's not coming and going. It only gets worse, right? So appendicitis doesn't really get better on its own. And so you'll see sometimes in the case of a non-diagnostic ultrasound inflammatory markers, but a child that's still sore, we'll admit them for kind of observation to see what happens. Because if they're appendicitis, they'll only get worse. And then you can see decreased appetite and fever. The key examination points, because there are a lot of eponymous signs for appendicitis. The ones that people really care about in OSCE or in an exam, tenderness over McBurney's point. And McBurney's point is, let's go that way, is this point here. So it's about 1/3 to 1/2 of the way between the anterior suprailiac spine and the umbilicus. Usually what I ask children to do is I say, if you had one finger to point to where it's most sore, where would you point? And the vast majority of kids with appendicitis will point literally to where that X is on their tummy. Other eponymous signs, there's a Rosvig sign, which is when you push on the right lower quadrant, they develop pain in the, when you push on the left lower quadrant, they develop pain in the right lower quadrant. The other word that's used for that, or the other kind of name for it, is cross tenderness. SWOTVAC sign is another one. So that's when you extend at the hip and the child develops pain in their abdomen. And that's usually when you've got a retrocecal appendix. So the appendix is sitting up against the psoas muscle causing inflammation. So that when you stretch that psoas muscle, as in hip extension, you end up with abdominal pain. Obturator sign is when you grasp the leg and internally rotate at the hip. And this is to look to see whether or not there's a pelvic appendix. And they'll develop pain in the same reproducible place in which they have it, which is usually in the right lower quadrant. Now, sometimes, so with these, so say you've got psoas sign and obturator sign, those are with two different locations of appendixes, if that makes sense. So although it's not impossible, it's really unlikely to have both of them be positive. So it's not like you're trying to tick off all these things, it's trying to kind of identify where the appendix is and if it's inflamed or not. We said the key investigations, which are bloods, urine, and ultrasound. And then the management, which you guys don't really need to know about, but is putting them on antibiotics. Here we use tazocin, IV, and taking the appendix out. Any questions about appendicitis before we move on?
Do we always need a prophylactic IV antibiotics or is it for preparation?
So the question, sorry guys, was whether or not, and I think the question is whether or not you need a preoperative dose of antibiotics. The evidence is for when you diagnose appendicitis, whether or not you've done it clinically or whether or not you've done it radiologically, you should commence on IV antibiotics immediately. And there is this thought, and I would have to review the literature to know whether or not this is supported by evidence, that if you get onto the antibiotics early, that you reduce the perforation rates. And so you reduce the difficulty of the operation, the soiling of the peritoneal cavity, and thus the length of antibiotics that they have to have post-op, and their length of stay, a lot of things. And so that's the rationale behind a preoperative dose of antibiotics. Sometimes we, in practical, we end up taking kids to theatre who we really don't think they have appendicitis. But we've been forced into an operation for whatever reason, whether or not our diagnostic tools have been insufficient to categorically say whether or not this person has appendicitis, and they're having a diagnostic laparoscopy to establish this before we kind of do anything to them. And in those children, some of them do not get antibiotics. Any other questions before we move off appendicitis? I promise you guys, this has been kind of the meatiest part of today's presentation, and everything should flow a lot easier after this. So looking at mesenteric adenitis, and I've really just kind of put down the key differences between this and appendicitis, just so when you're taking a history from someone, if you start ticking off a lot of these things, then you know that you're probably not going to go down the route of appendicitis. So the key differences for me, if there's a clear viral prodrome, whether or not there was an upper respiratory tract infection, whether or not it was a big rash or something like that, or whether or not it was even a gastrointestinal viral infection like viral gastroenteritis or something like that. Any of those things can cause inflammation and enlargement of the mesenteric nodes. And unfortunately, those mesenteric nodes are congregated around the right lower quadrant, and so will present with right lower quadrant pain. So yeah, the things like headache, a virally kid with rashes, kids that have preserved appetite, or those kids that get other symptoms before they develop their abdominal pain. So the first thing in appendicitis that you'll get is pain. Yeah, so you'll get pain, and then you'll get nausea, vomiting, fevers, and that's kind of the trajectory that happens. Not always, but that's the vast majority. And so when somebody tells me, oh, they were feeling unwell for a couple of days, did some vomits, and then only yesterday developed pain, that kind of stratifies them as a lower risk of having appendicitis, in my personal opinion. They should have a lack of those eponymous signs that we're talking about. The differences that you'll see in investigation is the majority of them won't have a super high white cell count in CRP. What you'll most likely find is what's called a lymphopenia. So they'll just have really low levels of lymphocytes. And that's because those lymphocytes have been consumed by the viral infection, or they're being utilized to fight the viral infection. And the reason why we care about the difference between them is one of them is treated with an operation and one of them is not. And so you just don't want to take a child that has mesenteric adenitis to theatre for an operation. Any questions about mesenteric adenitis before we move on? No? Okay. There's a pretty stock standard Google image of what mesenteric adenitis looks like. But essentially, these green things are the enlarged lymph nodes that are present in the mesentery, and the surrounding kind of red corona around them is the subsequent inflammation. Now, this is kind of demonstrated it like there's a node in the meso all the time. The majority of the times, there's actually just nodes in the greater mesentery of the small intestine and not in the mesoappendix, which is this kind of fatty triangle here. The last thing in tummy pain that we're going to talk about is Meckel's diverticulitis. And I really should have written Meckel's diverticulum, to be honest. But a Meckel's diverticulum is an outpouching of the small bowel, which is caused by failure of the separation of the vitellointestinal duct. You do not need to know the embryology, right? Like even at my level, like I don't get asked the embryology very often. Until you become an accredited registrar or a consultant, you're not usually asked it. The reason why I thought this would be helpful is occasionally it does come up in multi-choice and as well as written exams. And one of the key things to remember about Meckel's diverticulitis is a lot of the things about Meckel's diverticulitis follows the rule of twos. So it's an incidence of 2%. It's twice as common as boys. Presentation is usually less than 2 years old. Found 2 feet away from the ileocecal valve, so usually terminal/distal ileum. There's usually 2 types of tissue inside the Meckel's diverticulum, a gastric and a pancreatic tissue, and that's how they get their presentation. So they usually present in one of 2 ways, either with gastrointestinal bleeding, and that's going to be a lower GI bleed because it's after the ligament of Treitz, which is at the juncture between the duodenum and jejunum, or they'll come in with inflammation or infection. And the way in which they develop that is that gastric tissue that is inside the Meckel's diverticulum either erodes through an arteriole, causing a bleed, or causes ulceration of the mucosa, causing inflammation and infection. Right. Does anybody have any questions before we move off Meckel's diverticulum? No? You sure? Okay, yeah, there we go. Righty-ho. And there's just some take-home points which we've kind of talked about already. Righty-ho. Let's move on to case number 2, hey? So we have a 5-week-old term baby boy that presents with 4 days of vomiting. Really, really common presenting complaint and really, really fair game for any kind of OSCE when it comes to peds as well. So would anybody like to tell me what questions would you like to ask on history about the vomiting?
So contents of the vomit, if there's any bile staining or if it's food or if there's any blood even.
Perfect. That is the absolute crux of what I wanted to get to. So it's the character of the vomit that matters. And so when you said bile, what color is bile?
It's bright green, so not yellow.
Yeah, it's green. It's green. I personally, and other people have been called out when people said, oh, it's kind of yellowy. I think if there's any suspicion of bilious vomiting, it needs to be taken seriously. But yeah, bile is green. You're right. And so when somebody says my child is vomiting, the next sentence that comes out of your mouth is there any green vomits? Yeah, because usually if you've got good going bilious vomiting, they'll be like, yeah, there's definitely green stuff. So yeah, and then you said as well, whether it's bilious or non-bilious or whether or not there's any blood in it. Yeah, that's good. Any other questions about that you'd like to ask about vomiting?
It's like the timing of it, like how long they've been vomiting for. Is it right after meals? Is there any pattern to it in that sense?
Yeah, perfect. Yep. So that's really good. So it's about the duration of vomiting. Like, did this vomiting just start last night? Did it start 4 days ago? Or has this baby been vomiting since they were born? Exactly the pattern of it. Is it vomiting just after feeds, or is it like random vomits anywhere? Yep, that's good. Anything else? Yep.
The force of the vomiters, so like if it's proper projectile.
Nice. Yeah. And that's the buzzword that will come up in exams, in OSCEs, and everywhere else. And in life, people will swear black and blue that this is projectile vomiting. What projectile vomiting means, I don't know. Usually what I kind of say is like, does the vomit hit like the wall? Like, is it that projectile? Because, you know, some people would say like a forceful vomit, which is like a vomit downwards onto a child, is like projectile vomiting. But no, yeah, that is very important, like catchphrase for exams, definitely. Anything else about the vomits? Right, does any, same thing as before. So the other thing that we care about is whether or not the child has any abdominal pain, abdominal distension, whether or not they've got any kind of infectious symptoms, like other review of systems, sorry, like urinary tract infection and gynae history and stuff like that. Not in a boy, obviously, but the other things that are important in this scenario is about family history of vomiting. The other things that are important are what was the myth, just because we're kind of getting into a 5-week-old now, it's about what was the gestation of the baby. I've already given that to you, but what was the weight of the baby, how the baby's feeding. So does the baby take breast milk? Does it take formula milk? Is it fed by a bottle? Is it fed by a breast? Like all those kind of things are important, kind of filling things about getting an accurate representation of what's been happening with this infant. But you guys definitely clinched the major things that I would care about in the vomiting history. What are some of the key examination findings that you'd want to kind of elicit or look for in this child?
I guess looking at vitals, seeing how stable they are, as well as hydration status.
Yeah, those are by far the two most important things for this child, right? Because with looking at those vital signs or observations, looking at those vital signs and observations is going to tell you whether or not this child requires resuscitation, which is going to be the most important thing about sorting out with this child, right? And same with your hydration status thing. So if you look at this child and they're severely tachycardic, they possibly even at the point where they have hypotension, or they're have tachypnea, or their sats are low, all of those things are this is a sick baby. With the hydration status stuff, that's really good as well to see how far this kid is behind. And I'm sure you guys know most of them. The reliable things about looking at fluid status when you look at a child is that no single sign is really good, a combination of all of them together. And these are things when I'm talking capillary refill time, skin turgor, whether or not the mucous membranes are moist, whether or not they're shut down peripherally and cold. All of those things are kind of useless just on their own. But if you put them all together and you're yeah, all of these things are kind of lining up to say that this kid is hypovolemic, then you've got your answer. And some people say just for learning, I suppose, some people stratify the level of hypovolemia as mild, moderate, severe, depending on the percentage of total body fluid loss. So if you have less than 5, people call it mild. If you have 5 to 10% loss, people would call it moderate. And if you have greater than 10%, some people would call that severe dehydration or fluid loss, hypovolemia. Anything else that you guys want to look at on exam for this child?
If the abdomen's distended, or if there's any discrete masses you can feel.
Perfect. Yeah, that's exactly what I wanted to hear. So looking at the abdomen, is it distended there's an obstruction there? And is there a specific mass that could be causing that obstruction? So yeah, absolutely perfect. 5-week-old, trying to elicit whether or not they're tender. I mean, good luck. This 5-week-old that's distressed from vomiting is probably going to cry no matter what you do to them. What you can do sometimes is you can, maybe not in this scenario, but you can feed babies. So get them on the breast or get them on a bottle and feel their tummy whilst they're feeding. Right? Because sometimes that's going to chill a baby out so you can examine it better. All right, I think that's probably good for examination. In this 5-week-old term baby boy that's had 4 days of vomiting, can somebody or a combination of people come up with a differential diagnosis for this child? No answer is wrong. There's only different shades of right.
Pyloric stenosis.
Perfect. Yep. So idiopathic hypertrophic pyloric stenosis or pyloric stenosis is going to be the diagnosis that we need to exclude on this child to make sure that they don't have this. Yeah. Yep. And that's where this history is kind of taking you guys, is pyloric stenosis. Anything else?
Obstruction is secondary to vulvar intussusception.
Yep. So the other two that were thrown out here was an abnormality of intestinal rotation or malrotation with a volvulus. Also, intussusception was thrown out there as well. Yeah. Any others?
I guess if we're just talking about vomiting, could think of things like UTI or sepsis.
Yeah, 100%. Yeah. So an infection from any source could give you this presentation, right? So whether or not it's a UTI, like you were saying, or whether or not it's gastroenteritis, or whether or not it's meningitis can present like this as well, right? It's just this like flat kid that's had vomiting for 4 days. So yeah, that's really good. So we kind of nailed down a few surgical diagnoses like pyloric stenosis, intussusception, malrotation, but there's all those other ones that are like the medical diagnoses. Yeah, that's perfect. What do I think of anything else? Yes, I would, but you guys probably don't need to know that. That's fine. What investigations would you arrange for this child? Yep, abdominal X-ray is a really good place to start. And I suppose, what are you looking at? What are you looking for when you do an abdominal exam? Abdominal X-ray. What's the question you're trying to answer in your mind?
There's an obstruction.
Yeah. Is there any evidence of intestinal obstruction for this kid? And what would be radiographical evidence of obstruction?
What air fluid levels?
Yeah, air fluid levels. Yeah. What else?
Dilation of the large bowel, small bowel, depending on the obstruction.
Yeah, so dilation of bowel, and then one final thing. So okay, it's hard because it's an absence. So the features of intestinal obstruction on an X-ray are dilation, proximal dilated loops of bowel, wherever that kind of transition point is, and absence of distal gas. So if there's no gas that you can see in the rectum or the large bowel or anything distal, then you know that it's likely to be an obstruction at a certain point in the GI tract or alimentary tract, to be kind of a bit more broad. So yep, so abdominal X-ray. Any other investigations that you'd like to arrange? Anybody?
I think it would be reasonable to take bloods and maybe do a VBG, CBE.
Yeah.
See their electrolytes.
Yep. Not only is it reasonable, it's going to be the thing that's going to be the best thing for the child. The thing that you're talking about with the VBG is going to be the thing that changes what I do in my head for this kid if we think they have pyloric stenosis or not. So without getting too physiological with it, the physiological derangement that you find, or the electrolyte derangement that you find in pyloric stenosis, is a hypochloremic, hypokalemic, and hyponatremic metabolic alkalosis. Yeah. So when you do a gas and you see that they have hyponatremia, hypokalemia, and hypochloremia, and they've got like a pH greater than 7.45, in my head, I'm like, this kid is going to have pyloric stenosis, right? Because the only way that you can get that metabolic derangement is if you vomit heaps. Like you have to vomit so much to get that, because essentially you're hypovolemic at that stage from vomiting. It's not impossible to have another diagnosis when that happens, but at other centres, because I've talked up this ultrasound centre here, because they're so good at finding, but at other centres, because ultrasound is not as good and is a bit more of a precious resource, a lot of the time we wouldn't even ultrasound a child if they do not have that metabolic derangement. So yeah, bloods, VBG, CBC, you would need like formal electrolytes as well, and a CRP, of course, because we're surgeons. Not sure why it would be useful in this situation, but if I caught a boss without that, I'd be in trouble. Any other investigations? So we've talked about bloods and abdominal X-ray. Anything else anyone wants to do?
Maybe would you like want to check urine as well in case you're worried that it could be like a bit of a septic workup?
Yeah, 100%. It's very rare that I would not want a urine in a child, if you know what I mean. Just because the clinical manifestations of a urinary tract infection, especially in really young children, are so vague and the test is so cheap and so fast that it's it would be pretty unreasonable to not perform it, if you know what I mean. Because this history that I've given you could equally be a child that has a urinary tract infection and has sepsis secondary to it. So yes, definitely a urinalysis. Same thing looking for before, whether or not there's any white cells and whether or not they're nitrine as well. But any other imaging that anybody wants to do other than a plain abdominal X-ray?
Like a barium swallow? Would you do that now?
Yep, we tend to not do that these days, but it very much has been used. And depending on...
I didn't get that. Could you try again?
Sorry guys, Siri's in the chat as well. It certainly has been used before, and it is still used at different centres. So depending on what question you have in mind, so if you're asking, does this child have pyloric stenosis? Nobody would do a barium swallow for you. But if your question was, does this child have an abnormality of intestinal rotation, or what people call malrotation with a volvulus, then most certainly everywhere but here would do an upper GI contrast study or a barium swallow, which is what you're describing. Even though I've said that, there are some classical findings on barium swallow for children with pyloric stenosis. And that is what's called a string sign. So you'll see the contrast. Oh, I think I've actually got a picture. Let me check. Yes. So you'll see the contrast go down the esophagus into the stomach, and you'll see this little string sign where there's like a tiny little bit of contrast that sneaks through the narrowed pyloric antrum before it gets into the duodenum. You'll also see a phenomenon called shouldering, which is where if you look at the top of that string, I don't know if you guys can see my mouse, but if you look at the top of that string, there's a little shoulder at the superior edge just before it gets to the string. That's the shoulder of the pyloric antrum. And that's because that's where the muscle becomes hypertrophied back to normal muscle. Sometimes you'll see beaking or a bird beak appearance. And you might have heard that as well when you kind of look at achalasia, but that's in the esophagus. So yeah, barium swallow, people do it. But it's not standard for workup of pyloric stenosis. Any other investigations? So we talk about bloods, urine, abdominal X-ray. Anybody?
Ultrasound?
Yeah. Sorry, I feel like I should have just said it right. But yeah, abdominal ultrasound is going to be your key investigation in this centre for the workup of a child like this. And that's because abdominal ultrasound can exclude all of the surgical conditions we're talking about. So it can have a look at the pylorus, measure the length of the pylorus, the diameter of the pylorus, the thickness of the muscle, and it can tell you whether or not it meets the diagnostic threshold for pyloric stenosis. It can also look at the orientation of the SMA, SMB, which is going to tell you about whether or not the child has normal or abnormal rotation of the gastrointestinal tract. And it can also look to see if there's any interception. And so a lot of the time we get called in this centre about children like this and we say, look, just do an ultrasound. And if you find any of these three conditions, then just call us back and come see the kid. Does that make sense? Does anybody have any questions about this case before we move on to the actual specific conditions, which we'll whiz through?
I just have a quick question.
Yes.
The bloods. I can't remember if you said it before, but do we have to do cultures as well?
No, so I would not. The instance in which I do cultures on a child is if they had fevers. So say if this kid came in with 4 days of vomiting and their temperature is like 39, then yeah, definitely do it as a routine for a child that has fevers. And a child that just has no fevers, vomiting, looks relatively well, I wouldn't usually do cultures. And the kind of evidence for that is that the rate of positive cultures in children that don't have fevers is very low. Yeah? And that's because you're far more likely to develop fevers if you've got actual bacteremia, which is what you're trying to do when you take blood cultures, is identify bacteremia. Does that make sense? Or have I not?
Absolutely. No, that's good. Thank you.
Any other questions about this case before we move on? No? Okay. Let's go into some specific conditions, hey? And again, this is more just so you have it here because I know talk fast, and I've got a New Zealand accent, so sometimes it's nice to kind of see it written down. But the proper name for pyloric stenosis, not that you have to say it, is idiopathic hypertrophic pyloric stenosis, and it kind of gives you an idea of what the cause of it is, right? So there's hypertrophy of the pylorus, and we don't know why, and it results in gastric outlet obstruction. The risk factors are important because sometimes when you get a stem, it will be like, oh, this 5-week-old male firstborn twin pregnancy child whose mum used antibiotics in pregnancy and is bottle fed and has a strong family history of pyloric stenosis. What do you think it is? Then you're just like, well, they've got every single risk factor under the sun for pyloric stenosis, so they're probably leading me towards the thing that is pyloric stenosis. The key features on the history we've kind of talked about, so it's the projectile vomiting. The one thing that we didn't talk about, which is really, really sensitive to pyloric stenosis, is a parent will say, my child vomits heaps, and then they're immediately hungry after the vomit. And the reason why they're hungry is that they just haven't absorbed any of that feed that's gone in. Another thing that they'll say that I haven't actually put down here is they'll be like, their vomit smells, because it's literally just milk, breast milk that's just been sitting in their their stomach for a long time. Yeah. So sometimes people will say like, oh, there's like curds of stuff in it, if that makes sense, but partially digested milk. The vomit is, not that I put this in there either, should have put so many things in there, is almost always milk, right? So it's not going to be bilious, it's going to be milk. The other key features is obviously they're going to be dehydrated. Sometimes they're going to be malnourished, depending on how long they've been going before they get to you. What we didn't put in there, the age range for pyloric stenosis, and this is not an absolute, but it's usually between about 3 to 6 weeks of age. So usually if they're like referring me a kid that's 7 days old, I'm going to say this is really unlikely. If they're referring me a kid that's 6 months old, I'm going to be like, this is really unlikely. Okay, so it's that 3 to 6 week age range. And I think ped surg is hard because there's all these conditions that have this specific age group. Like when we get to intussusception, it's like 3 months to 3 years. You know what I mean? So it is harder than adults where you've just got, this can happen at any time. Key examination features, and these are just buzzwords to use when you're in an OSCE and you think it might be pyloric stenosis and you're looking for things, and you can say, I see no visible peristalsis. And when you palpate, you're like, I can't feel a palpable olive, which is a hypertrophied pylorus. Now, the reason why you get visible peristalsis is that the gastric contractions get so forceful because they're trying to force milk through this narrowed gastric outlet obstruction that you can see a visible wave going from the left upper quadrant into the epigastrium. I've never seen visible peristalsis on a kid with pyloric stenosis, so it's really rare. I have felt maybe 4 palpable olives in kids. So the actual examination of a kid with pyloric stenosis is usually not very helpful at all. Yeah? So the key things are going to be the history, the investigation on the blood gas, so that hypokalemic, hypochloremic, and hyponatremic metabolic alkalosis. That's always a bit of a mouthful. What I remember is all of the electrolytes are low. One, because you're vomiting out the chloride, you're vomiting out the potassium. And then what happens with the sodium is that to re-establish volume status, what you do is you selectively reuptake water via the renin-angiotensin system, aldosterone, and H. So it's ADH that inserts into the collecting duct, which then results in the increased production of aquaporins and reabsorption of selectively just water, which gives you the hyponatremia. You don't need to remember any of that. And the management of pyloric stenosis is not a surgical emergency. They can wait until they've been adequately resuscitated, their electrolyte abnormalities being corrected, and then we'll do our operation for them. Anybody have any questions or anything they want to ask about pyloric stenosis? No? Okay. Sorry, guys. I know this is taking a long time, so feel free to leave if you need to leave. and we'll just keep on going through. This is the contrast study that we saw. I just thought I'd put up an image that was stylized with Thiccan pylorus, so it's there for you. Really quickly on intussusception. So intussusception is telescoping of the bowel, where the proximal portion of the bowel invaginates or kind of telescopes into a distal part of the bowel. And it results in intestinal obstruction because that proximal part occludes that distal part. The most common place in which intussusception occurs is in the ileocecal region. The age group we talked about before. There's non-pathological lead points. So sometimes kids will get a viral infection. They'll get a hyperplasia or an increased size of their lymphoid tissue in the Peyer's patches, which results in when the bowel peristalsis gets caught on that and can't go backwards, and it keeps peristalsis through and causes the telescoping. That phenomenon can happen on anything, whether or not it's on a big nasty appendix, Meckel's, lymphoma, duplication cysts, like anything that's a bump inside the tummy. The key points on history for intussusception is that they'll have bilious vomiting because the obstruction is distal to the ampulla vata, or the place where bile comes into the gastrointestinal system, whereas the obstruction in pylorostenosis is proximal to that point, so it's always going to be non-bilious. Kids with intussusception will also have abdominal distension and won't have any stools or flatus because they're obstructed. The key examination findings is that you're going to have an empty right lower quadrant because the bowel is kind of not twisted, but telescoped itself all the way around. And so you'll end up with a left upper quadrant or epigastricus. The key investigations that we do is an X-ray and an ultrasound. And on an ultrasound, we see something called a target sign, which is basically you see the bowel and you can see the loops of bowel inside the bowel. And so it looks like a target. And the way we cure it is by an enema. So we stick a catheter up their bum and we put either air or water up it under pressure. And what it does is it just pushes that proximal bowel or de-telescopes it outwards. And if that doesn't work, they need a laparoscopy where we can pull it apart ourselves, or sometimes even a laparotomy to cut out dead gut. And that's just a stylized picture of the intussusception, the ultrasound finding of the target sign. And then this bottom image is, let me just move that. This bottom image on the left is a air insufflation enema. So you do it under fluoroscopic guidance. So you put the catheter in the child's bum, you pump it up like a blood pressure cuff, it pushes air through, and you can see it going up that descending colon over into all of a sudden, and that will be at this point where it stops because it's trying to push this through. And then as you increase the pressure, what happens is it pushes it back, and you can see that the air has been able to get into this point here, which is all small bowel. And you can tell it's small bowel because it's central and there's multiple loops of it. Whereas the large bowel here, you can tell it's large bowel because it's peripheral. Righty home. That's intussusception. Malrotation. You guys don't need to know too much about this, except that it is bad. Okay. Malrotation kills children, and so it's something that we just cannot miss. So malrotation is essentially a spectrum of abnormalities where there's an embryological failure of the gut to undergo the proper rotation, which means that the gut ends up in a malrotated position. And what that results in is a propensity for the small bowel to volve or to twist on itself and causing obstruction. The reason why it's so bad is because this gut gets ischemic really fast. Dead gut, then you can sometimes end up with a dead child. Can present at any age, but the time that we care about it the most, the kind of blurb that you'll get in an exam is it'll be like this 2-day-old infant with bilious vomiting, and that's malrotation until proven otherwise. Bilious vomits of any nature is like in ped surgery, is malrotation until proven otherwise. The key features of an exam are just those of intestinal obstruction. Key investigations are an X-ray to demonstrate the obstruction, an ultrasound, and then everywhere else an upper GI contrast study, but at this center ultrasound. What the X-ray findings will be is they'll have a big dilated stomach and a paucity of gas in the small bowel, because there's been enough, you can get gas through to like maybe the duodenum, then it can't get past there because that's the point of obstruction. So you'll sometimes look at an X-ray and be like, oh, I can't see any big dilated loops of intestine. Everything's fine. But that's because you can't see anything in So I think that's us for, and this is just, so the middle image is kind of trying to demonstrate what the normal embryological process is. So don't need to go into it too much, but the gut herniates out of the what will become the umbilicus, undergoes a first stage where it rotates 90, well, they've said it's second stage here, where it rotates 90 degrees. And then what happens is it comes back inside the tummy and rotates a further 180 degrees. You don't have to remember whether or not it's clockwise or anti-clockwise. It's clockwise, but it also depends on whether or not you're the baby or whether or not you're the person looking at the baby as to whether you see it's clockwise or anti-clockwise. Essentially, the catch thing that I would say is it undergoes 270 degrees of rotation. And so you can see how a straight tube here ends up being the normal configuration that we see here. On the image on the left-hand side of the screen, you can see the normal one, which is A, and then you can see B, which is an abnormally rotated gut. Those bands going across underneath this arrow are what's called Lanz bands, and that can also cause obstruction. And what you can see on the right image is a upper GI contrast study where we've put contrast into the stomach, which they've handily labeled, and then here's the duodenum, and you can see they've said Z sign. We don't usually look for a Z sign. The thing that we care about is whether or not you can see the DJ flexure at the left-hand side of midline. And over here, the part where the duodenum becomes the jejunum is on the right-hand side of the tummy. Righty ho. So that is our approach to vomiting. Any questions about vomiting before we move on to groin stuff? We've probably got maybe another 15 minutes left in us, guys, if you can hang on a little bit.
I just have a quick question about malrotation. Can you get malrotation without volvulus and volvulus without malrotation, or do they always occur together?
Nope, not at all. So you can get malrotation without a volvulus because I suppose, like, if you're going to be, because I've said it can occur at any age, the malrotation or the abnormality of intestinal rotation is always like a congenital abnormality, right? Like, is it always present? And so every now and again, we had one a few weeks ago where we found an incidental finding of malrotation on an ultrasound for like a completely different thing. Like, I don't know what the kid was actually having an ultrasound for, but they found malrotation. That kid got a laparotomy that night without having any sign of volvulus. The kid was completely well. We operate on malrotation without volvulus all the time. And that's because, unfortunately, they can volve at any point in time. And if you've got a kid that's even like had 4 hours of volvulus, they could have a completely dead gut. Now, your other question about can you have volvulus without an abnormality of intestinal rotation? Yeah, it's possible. The volvulus usually occurs in other places. So it will either occur in the sigmoid because it's got its own mesentery that can sometimes be really mobile, or it occurs in the cecum when the cecum is really mobile as well. Small bowel volvulus can also happen without an abnormality of intestinal rotation in a certain circumstance where the mesentery is really narrow. So you know how like the mesentery is like a big kind of triangular umbrella thing that comes out and the bowel's kind of all at the bottom of it. You can kind of see it in the middle image and the bottom right, where you can see those big arterial arcades coming out from a central point, which is the superior mesenteric artery. So the reason why you get volvulus in an abnormality of intestinal rotation is that the mesentery is really narrow. So when you look at the left-hand image in A, see that dotted line? That's the axis of the mesentery, and that's the length of the mesentery. And in image B, on the left image B, you can see those dotted lines is way shorter and way narrower. And because of its narrow nature, that predisposes it to twisting and causing that small bowel volvulus. Does that make sense? I'm going to assume yes. Any other questions about vomiting before we move on to groin stuff? No? Okay. So, case number 3, and I think this is our final case. So we have a 6-month-old extern preterm boy, I've been doing boys heaps, haven't I? Presents with a swelling in his left groin. Anybody have any further questions that they'd like to ask on history for this kid?
Yeah, has it always been there?
No. So, sorry, that's a very important question. Sorry, I was answering like I was like the person's parent. Yeah, that's possibly the most important question in this history. Yeah, because I suppose, what are you trying to get at this when you ask that question?
I guess we're trying to see if it's a hernia.
Yeah, exactly. Because a hernia would be an intermittent phenomenon, right? Like there's a congenital defect that allows the passage of a body part, usually fat, outside of the abdominal cavity, but then when the pressure lessens, it goes back inside and outside and inside. So yeah, the intermittent nature of the swelling is probably one of the most important aspects of this history. Any other questions anyone wants to ask? Sorry.
With it being intermittent, you could ask if it's worse when they're like crying.
Yeah. So that's another really important point. So we've established whether or not it's intermittent. The thing that I think you're trying to establish is what are the factors that accentuate the swelling, and are those factors ones where there are raised intra-abdominal pressure? So when they're crying, when they're like, for an older child, like running around playing sports, is it when they're pooing? Is it when they've got a viral respiratory infection and they're having to breathe a lot harder and push a lot more and use their tummy muscles to do so? So yeah, very, very important point in the history.
I guess if there's ever any erythema of the abdomen or anything,
yeah,
or any tenderness.
Yeah, absolutely. So completely agree. So whether or not the swelling itself has any induration, erythema, signs of infection being the primary pathology. You're talking about things like whether or not the child's unwell, do they have a fever, have they complained of tummy pain itself, rather than just this intermittent swelling, all really important. And the main thing with that erythema of the lump is if you've got like an incarcerated an incarcerated hernia is one that's stuck, that can't move, right? But you can have an incarcerated hernia that has healthy bowel in it, or just like fat in it that's nice and healthy. You can have a strangulated hernia, which is where there is now bowel, impaired bowel arterial perfusion, and then you can have an ischemic one. Now, the key thing here is if you've got skin changes, you're likely to have a strangulated or ischemic gut. And so that, for me, is a really important question in history, because it stratifies how worried I am about the kid. So yeah, really, really good. Any other questions anyone wants to ask about the lump for the family?
Yeah, are they separate to the testes?
Yeah, that's also a really important point, because the lump in the groin could just be an undescended testicle or a retractile testicle. So yeah, really, really important to ask them, hey, when you see that lump, is it just in the groin, or is it in the groin and the scrotum? And if it's just in the groin, can you see the testicle separate to it? And if they're like, yeah, I can see the testicle separate to it, then you're like, okay, I think even more likely this is a hernia rather than just an undescended or retractile testicle. Yeah, so really good. The other thing that I would ask, and I've kind of put it in that blurb, is that you're more likely to have a hernia in a preterm baby. So ones that aren't term, and that's because they haven't had the time to embryologically separate the two cavities of the tunica vaginalis and the abdominal cavity. Cool. Now, we've kind of talked about this already a bit, but what are the key things on examination for a swelling in the left groin? Like, what do you want to do, and why do you want to do it? Like, what do you want to?
I guess sort of on palpation, I guess, whether it's separate to the actual testicle.
Yep. Perfect. Yep.
Like whether you can get above it and sort of all that.
Yeah. So my question is, can you get above a hernia?
No.
No, yeah, you're correct. Yeah. So you cannot get above a hernia. And the reason why you can't get above a hernia is that in children, about 95% of the time, they're what's called indirect hernias. So they come through the deep inguinal ring, along the canal and outside the superficial ring. And so when you've got a lump there, you won't be able to get above it because above it is inside the tummy, if you know what I mean. Whereas I think what you're describing is, not what you're describing, I think the key thing that you're differentiating in your head is if you can get above the lump, then it's unlikely to be a hernia, and it's more likely to be something like a hydrocele or a hydrocele of the cord or a cord lipoma or like a lymph node. If you can get around the lump in its entirety, it's probably not a hernia. So yeah, very, very important examination point. Any other examination points?
In that point, would you add about whether you can reduce it or not?
Yes, yeah, that is the most important thing. Yeah, for like once you've established that, I think this is the hernia. Reducibility is the most important thing, because as soon as you can reduce a hernia, like I'm not, you've turned an emergency into something that's just not an emergency anymore, right? So if they've got a really easily reducible hernia, you can think about doing, because all hernias, this is another important one, all hernias need a surgical fix in children. You can't just leave them alone. I mean, they just need it, they need them. And so reducibility stratifies when you're going to do this hernia repair. If you cannot reduce it, the hernia repair is now. If you can reduce it, it's later. And like we could talk till the cows come home about when we actually fix hernias, and it's different for different age groups. Usually I like to use the 6 and 2 rule. So if they're less than 6 weeks old, you should probably fix them within 2 weeks. If they're less than 6 months old, you should probably fix them less than 2 months. And if they're like less than 6 years old, like you can kind of do them whenever you want to. They're not, their propensity for them to become incarcerated and strangulate and have dead gut is far higher when they're younger than when they're older. Yeah, so that's it. Any other points on examination that anyone wants to yarn about?
Probably checking for chromastoid reflex as well.
Yeah, 100%. Yeah, especially in those instances where it's an inguinal scrotal hernia. So the swelling is not just in the groin, but it's in the scrotum as well. And what you're trying to differentiate is whether or not this person has an acute scrotum, right? You're trying to differentiate, does this person have like a neonatal torsion that I'm missing? And if they have an absent chromosteric reflex, then it's, you're going to start thinking, well, do I actually have like a dying or dead testicle in there that I need to do an operation for right now? So yeah, definitely. The other things that I would say is I would always examine the other side to make sure that there's no hernia there. And I'd also have a look to see if there's any other lymphadenopathy to support whether or not this is just a bunch of lymph nodes and one big one there. Any investigations that anyone wants to do? Say, let me. Oh yeah, no, you go.
Had one question. If you do see overlying skin changes, do you still try to reduce it, or at that point is it surgery?
That's a really, really good question. A lot of people would have different answers. I think my answer, my catch-all answer here, or let's say why that's controversial. So the reason that that's controversial is that some people would say if you've developed overlying skin changes, you're going to have dead gut there. And if you attempt to reduce it, you can cause the perforation and cause the intra-abdominal soiling that you're going to get secondary to that perforation because the integrity of that bowel is compromised. Others would say, look, the problem is that it's stuck there. And if you can get it back inside, even if there's skin changes there, they're going to need an operation. Nobody's disputing that. But if you can get it back inside, stabilize the kid, then we're going to have a healthier kid to operate on, if you know what I mean. So it is controversial. What I would do is I would attempt to reduce the hernia. I would think that I would be lucky if I got it back inside, because if you're at the point where there's skin changes and swelling and erythema, then it's probably so much edema in the intestinal wall that you're really unlikely to be able to fit it back through the superficial ring, the canal, and the deep ring. But yeah, really, really good question.
Thank you.
Anybody want to, does anyone have any investigations that they want to do for this kid? Let me say that the child is completely well. This has just been found incidentally. Mum was like, 4 days ago, we noticed this hernia, this like intermittent swelling in the groin. It just got a little bit worse today, but we can still easily push it back in. The infant's well, peeing and pooing, like no fevers, like no vomiting, nice soft tummy that's non-distended, and you can easily push it back in. Does anyone want to do any investigations for the kid?
Would you be pretty happy then that it's an inguinal hernia and you don't need to x-ray?
Yeah, I would. Because the only thing that you're doing an x-ray for is to check whether or not the kid's obstructed. An x-ray can sometimes help you very occasionally in the when you're in a part of diagnostic uncertainty. So if you're like, look, I think this is a hernia, but it's really weird that I can't reduce it and the kid is still so well. And so sometimes you can x-ray those children. And if you don't see any gas below the level of the pubic tubercle, so I say that because like if you got a girl, like it's not going to be in the scrotum, if you know what I mean. So if you can't see any gas below the level of the pubic tubercle, you can be like, I think it's really unlikely to be a hernia. Whereas if you see that there's gas below the level of the pubic tubercle to kind of imply that there's bowel down there, then you're like, okay, I actually do think there is one. And I think I'm just unable to reduce it. So it's an incarcerated hernia. And I think I need to get somebody more experienced to reduce it for me. Yeah. Let me race through some stuff. Sorry, guys. I know we've been going for so damn long. So there's just some stuff there. Everything that we've talked about. Some pictures there about the inguinal ring. In that middle image, there's like a swelling in the right groin of the child, which is most likely a hernia because you can see two testicles. Let's go faster. Undescended testicles usually give a lot of people a lot of problems in terms of OSCEs and writtens and stuff like that. The main thing to consider is that I usually like to call it testicular maldescent. So testicles normally descend from the posterior abdominal wall down through the deep ring, through the canal, pop out through the superficial ring and end up in the scrotum. The testicle can arrest anywhere along that point. So it can be intra-abdominal, at the deep ring, in the canal, in the superficial ring, or in the proximal scrotum, or it can even be ectopic, so anywhere along the medial thigh. The key examination point is whether or not it's palpable. Because if you can feel the testicle, if you can't feel the testicle, then the child's either going to need an ultrasound to find the testicle or for you to do an operation to put in a laparoscope to see if you can find it on the inside. If you can feel the testicle, then the key decision point is, can you bring the testicle all the way down to the scrotum? And if you can, then it doesn't need an operation. If you can't, need it. The next thing to have a look at is to see how well the scrotum is developed. And the operation for it is what's called norpepexy. So a pexing or fixation of a testicle down. Here's a picture. Very quickly on urology issues, phimosis. So phimosis is an irretractable foreskin, and the reason why it develops is because there's adhesions from the glands to the foreskin. It's normal in young boys all the way up to the age around about 7. 90% will resolve spontaneously by this age. The reason why we care about phimosis is that it can cause pain, recurrent balanitis, so they can get infections of the tip of their penis because of bacteria underneath that's trapped there because they can't get under there and clean it. You can even get urinary tract infections from it, and abnormal urine stream, so urine stream kind of forking everywhere. The key part of the examination is being able to tell how far you can pull the foreskin back. So you can say, like, I can get it to see about 50% of the glands, or 75% of the glands, or 10% of the glands, or I can't see any of the glands. The other key thing is to see whether or not there's any of these white scars, which are indicative of BXO, and whether or not there's a healthy meatus. You don't need any investigations, and what we do is we ask people to put some steroid cream on there because it dissolves those adhesions. If that fails, they get a circumcision. And this is some pictures of some white scarring on the glands to indicate BXO. And literally the final thing to talk about today is hyperspadias. Not really too much to say about it. The only thing is that it's made up of 3 distinct abnormal anatomic characteristics: a bent penis, so chordy, an absent ventral foreskin, or some people call that a dorsal hooded foreskin, and an abnormally positioned urethral meatus. And the severity is classified based on where that meatus is. The key points on examination is saying how bent the penis is and adequately describing where the hole is. They don't really need to do any investigations, they just need a hypospadias repair, and there's about 100 to do that. This is a picture kind of signifying where the meatal opening can be, and whether or not, so you can describe it based on where the hole is, or you can say that it's anal or the other words for that, distal, middle, and proximal. So that's basically it. That's, I don't know how long that was. It was like an hour and a half of pediatric surgery, but that should be the vast majority of conditions that you guys need to know, and an approach to kind of working up those children. So abdo pain, vomiting, groin issues, and urology are by far like about 90% of what we do here. Does anybody have any questions about what we've covered today, or anything that they think I haven't covered that you guys would like to know, or anything?
I was just wondering if you'd be able to repeat that 6-2 rule for the management of hernias again.
Yeah. And the 6 and 2 rule is a general guideline rather than like a Cochrane review evidence-based approach to the management of hernias. But it's really useful because that's what most of us follow. So we'd say if a child has a diagnosed inguinal or inguinoscrotal hernia and they're aged less than 6 weeks, we would aim to do their herniotomy or their surgical correction within 2 weeks. If they're aged 6 months or less, we aim to do it within 2 months or less. And if they're 6 years old, you can say 2 years, but usually what we do is we put them on an elective list, like category 2 or 3, if that makes sense. So they're not a rushed thing to do.
Thank you.
That's all good. Anybody else got any other questions or things they want clarification on, or things that they think I've missed? But it's basically most of the stuff that you'd be asked to know. Cool. If that's it, thank you very much for having me, guys, and I hope that was useful in some way, shape, or form.
Thank you.
Thank you very much.
Thank you.
Thanks, Megan.
You are all very welcome. Fly away and pass every exam. You guys will